methods due to the time lapse, which takes up to 72 hours to bring a result. It takes more time, or it takes more time for the patient to stay, which also affects the mortality, and also affects the hospital cost as well. What we did is that we evaluated the performance of Univer hospitalized pneumonia. It is a multiplex PCR based method to detect bacterial pathogens from the lower respiratory tract samples. We have obtained samples from children with CF from the pediatric clinic of the University of Kosovo. The Univer platform consists of the two devices, the Univer system and the cartridges we use for our work. It is, as I said, a multiplex PCR technology which detects a wide variety of microorganisms and antibiotics resistance markers, whereas we get the results within under 5 hours. This is the panel, HPM panel, that is available from gram-positive bacteria, enterobacteria, non-fermented bacteria, and resistant gene. So it is a wide panel of identifying microorganisms. How it works? It is a simple. It is automated, entirely automated. I said it simplifies the work when we have a detection of more than one pathogen. So this makes the results faster in order to start the adequate therapy for treatment. The number of samples that we received is 35. 25 of them resulted with Pseudomonas aeruginosa. And we have 4 cases with 4 polymicrobial isolates: Staphylococcus aureus, Anictobacter baumannii. So this is the advantage when using these methods. So it gives us the chance to isolate more than one bacteria in the sample. This is also the percentage of genes which are responsible for resistance in antibiotics. We have a 28.57%, A83, and then we have 9.5% TEM, 4.76% VIM, and OXA24 followed by. So rapid methods, or quick methods, have a very important role to detect pathogens and markers that are responsible for resistance in antibiotics. This, of course, fastens the way of reporting, improves the patient's outcomes, reduces mortality, and makes the patient stay less time in hospital. It is, as I said, polymicrobial isolates identification is very helpful. I have put a plate here. It's Pseudomonas aeruginosa, pediatrician patient. These are tests. We can see the dot one below, and that is the cholesterol there. We have resistance, an isolate resistant to almost all antibiotics tested based on the EUCAST protocol. Of course, this is concerning because that's why these molecular methods fastens the reporting way to the clinic in order to be more adequate on prescribing the antibiotic. What in the future? In the future, we should invest more in diagnostic methods, molecular ones I prefer, point-of-care testing, that these equipments are close to the patient in order to have them faster, to get the result faster, It would be, desirable, to have a surveillance of genomic surveillance. We also consider that this diagnostic method be performed in a routine way. All CF patients, especially, we possess a very small number of tests due to high cost of tests. We use with patients that have indications, or when a clinic calls and requires and tells that it requires the results faster. In a routine, we find it rather difficult to work on it due to its high cost. A short history of our lab. We are established in 2020 as a result of an agreement between the government of the Italian Republic and the government of the Republic of Kosovo, which is done through the project Support to the Health System of Kosovo. This project has resulted with a fully equipped lab, but we are every day being equipped with new equipments, more staff. Our future plans are to increase the test numbers, types of tests also. We want to set 12-hour working hours, as we currently work only with 8-hour working hours. So we want to be more available to the clinic for to bring the results, and also be present in different departments, not only with the pediatrician department, but also other departments when you're dealing with prescribing therapies with antibiotics. Activities currently ongoing are supervision and control of the nosocomial infections, antibiotic stewardship, and having more contacts with other clinics, staff from different fields.
I would like to call to the floor Eric Ulzerbos for a talk on chest physiotherapy as part of CF lung disease treatment.
Thank you. I will also thank the organizing committee for the opportunity to present here, and special Flora and Katerina to give me a floor to tell you about the role of physical therapy in the CF care, and also the role of the physical therapist in the team. I hope it was working. Yeah, can you put the next slide, please? So the role of physical therapy in the CF care, but also in the team, is, I think, an important point is inhalation therapy. The choice of the appropriate medication, and a specialized inhalation medication in combination with the airway clearance technique. I think the timing, also the use of inhalation medication, it's important, but also to train the patients and family in the optimal use of the combination of inhaled medication, but also in combination with your airway clearance techniques and therapies. So airway clearance therapy, I think, is also an important point of the physical therapist. possibilities in patients with cystic fibrosis, and also look at the breathing pattern. I think that's the first step in a good airway clearance therapy, that there's a normal breathing pattern. In our workshop this afternoon we give some idea and some information how to look at the breathing pattern. Is it a normal breathing pattern or a dysfunctional breathing pattern? How can you make the breathing more efficiently? And also the choice of airway clearance techniques. There are a lot of different choices with and without devices. And I think also without devices you can give a very good way to airway to open and to clear your airways with mucus. And also training patients but also caregivers in the optimal use of the different techniques. Physical education, I'm also a member of the exercise working group in cystic fibrosis, and we make a lot of guidelines about exercise testing but also about exercise training. And I think exercise and development plays an important part also for the physical therapist, and to start as soon as possible and also look at musculoskeletal problems and postural problems, and also management when there are problems in the musculoskeletal and also in postural, postural. And last but not least, education, improving and updating the state of the art. There are a lot of articles and guidelines are already published in journals, but also to locally involve physical therapists and patients and families about these guidelines. So when we look at the inhalation therapy, there are a lot of goals for inhalation therapy and inhalated medication. So you can use inhaled medication for losing the mucus, but also for hydrate the airways, open up the airways, reduce inflammation of the airways, and or to deliver antibiotics to treat infections. So there are a lot of goals, of indications to use that medication. What already told in this talk this afternoon, there are different nebulizers and inhalers available on the market at the moment. So I think it's also important as a physical therapist to know all these different devices, and also discuss with your CF team which device is the most appropriate for you as a patient. What I told before timing of inhaled medication, and also the inhalation with the different medication, but also in combination with your airway clearance techniques is important, and also to ensure to make a daily program. You can see on the right side on the slide, to make an airway clearance plan with the patient, when to do which kind of medication and which kind of airway clearance technique. So there are different airway clearance techniques available, but I told you there are a lot of devices, but also without the device you can do a lot of good things in people with cystic fibrosis, and you can choose different position to do airway clearance techniques. You can front or back or in sitting position, and look in which position your sputum evacuation mobilization is most effective. The active cycle of breathing technique, we give you some more inside information and background about this technique. It's a very easy technique, and it's a technique consists of different exercises, like breathing control, thoracic expansion exercise, but also forced expiration technique. And you can do it without devices, and when you do it right, on the right way, it is very effective treatment for mucus mobilization, but also for your mucus evacuation. Now, devices, positive expiratory pressure already mentioned, and also oscillating PEP. There are a lot of evidence to, when you use evacuation techniques, that positive expiratory pressure is important. You can do it with a device, a PEP device, or an oscillated PEP device, but also with pulse lip breathing. So also these techniques you can do without any devices. And important, I think, is gentle huffing instead of coughing, because coughing gives a lot of stress and pressure on the airways, and when you do learn the patients to do a gentle huffing, it's very effective in evacuation of your sputum. And also mentioned before, previous speakers encourage people to do aerobic exercise. because participating in different physical activities as running, walking, also dancing. Tonight we have a dancing, I heard. Is the dancing also tonight? Maybe Flora's, the floor is for Flora tonight for dancing. But all those exercises are very important to promote and to make your airway clinics more effective. So there are a lot of benefits of physical education, also exercise, and the most important is, of course, enhance and increase your cardiorespiratory fitness. And we told you a little bit more how to test your cardiorespiratory fitness in the workshop, so come to the workshop this afternoon. But also physical education and exercise are increasing your mucus clearance, but also delay the onset of dyspnea. Especially the work of breathing can decrease, but also you can make your ventilation more efficient for oxygen uptake, but also for carbon dioxide. But also delay declines in your pulmonary functions. There are a lot of publications already when people start with physical activity of contain their physical activity, you can decline or increase your pulmonary function. But also to prevent decreasing bone density, exercise can be an important treatment plan, and also to enhance your cellular immune, but also metabolic response. We told the diabetes population will increasing when patients with cystic fibrosis become older. And also it can improve quality of life and improve self-image, confidence, and also psychological benefits. So there are a lot of benefits for physical exercise. So there's no reason to be inactive. Also, I think an important part of a physical therapist is to look at the clinical manifestation in the musculoskeletal system in people with cystic fibrosis. And most of the time, when you look at the posture, you see an increase in thoracic kyphosis. So I think it's also an important treatment plan to get and look at that postures, but also keeping the spine, but also the thoracic more flexible. So mobilization exercises by manipulation, mobilization, but also with homework exercises is helpful to decrease the work of breathing and to get a free way for breathing. Also muscle atrophy and myalgia, difficult word, is a topic in people with of patients with cystic fibrosis, but also osteoarthropathy, arthritis, and also osteoporosis. So there are a lot of indications to do a lot of exercise, and also weight-bearing exercise for your skeletal system. So education, now there are a lot of standard cares, and in the United Kingdom have published this standard of care of good clinical practice, and you can see a lot of contents in this guideline, and a lot of contents about inhalation therapy, also about oxygen therapy, but also musculoskeletal problems and postural management. So you can read it. It is free available on this website. So my take-home message is, I think for the physical therapist, but also for the medical doctors and the patient, is use airway clearance techniques. Are recommended for all patients with cystic fibrosis because it increases your mucus clearance, but also maintenance of your lung function and also improve your quality of life. Now, what we mentioned, Dr. Fabio already mentioned, there's no airway clearance technique that has been demonstrated to be superior to each other. So it's this personalized care is important to choose the right airway clearance technique. And also the prescription of airway clearance technique should be individualized, so personal-based care. And it depends on the age of the patient, but also the preference of the patient, also the adverse events of the patient. And last but not least, aerobic, but also exercise and strength training is recommended for all patients with lung disease. Now, it has a lot of benefits, but also the benefits for overall fitness and health, but also for your cardiorespiratory fitness, but also for your musculoskeletal health. I think exercise is the key factor in your treatment plan. Thanks for your attention.
Thank you very much for your comprehensive presentation, Dr. Eric. Next is Dr. Aryan Selmani from North Macedonia, presenting autogenic drainage on spirometry parameters in different ages of patients with CF.
Thank you. Welcome, everybody. Well, I want to congratulate, first of all, about this organization for the first time in Republic of Kosovo. And I am here to present my presentation with two interesting cases with cystic fibrosis by using the best method in treatment of the patients with cystic fibrosis, the autogenic drainage, by using as a tool, measurement tool, the spirometry, to see how this works to cystic fibrosis patients. Well, I don't have why to stop here more. Everybody knows what is cystic fibrosis, so we have here, it is a genetic disorder that because of that CFTR genetic mutation, the protein which controls the ionic conduction, it's, of course, it's dysfunctional, and that's why we have a thick mucus or epithelial lining. In the epithelial lining fluid, we have this mucus is so thick, and that's why we need to use techniques that are the best to clear this mucus, to don't let to collect in the airway tract. So there are difficult signs that different signs that how cystic fibrosis appears to the patients with CF. So we have so it is a multisystemic disease. It affects all organs that, of course, which has where we have this mucus which needs to transport this fluid, and so the most frequent part that we, like a physical therapist, we want to stop and we treat, it is the lungs. So the most problem that we have during our work, it is, so this cycle is very important. We have mucus. We need to expectorate or to take it off. And this is where the house of microorganisms are standing. So if we don't expectorate the mucus, they will build a house. That's why we need to use our techniques to collect this mucus and then to expectorate. If we let the mucus inside for a long time, of course, we will have infection, and we will have, again, mucus reproduction, and finally, we have obstruction. So this is how it starts. So we have a gene defect, abnormal CFTR gene, and we have dysfunction of that protein in the epithelial lining. So we have dysfunction in the natrium and chloride transport abnormality. We have everything, all the impairments that are written here. So where it causes infection, inflammation, and then production of that mucus. You can see also in the picture how that epithelial lining where this fluid should be, and where this fluid, it stuck here because of thickness, and the function of this, as you see, we call it epithelial cilia, where they help so that fluid to have a sliding of the fluid or the mucus, and this function is also impaired, and we have difficulty to expectorate or to mobilize that mucus. So, we use different techniques. We start from the upper respiratory drainage, where we do the upper respiratory airway clearance. So we use different tools to use this drainage. And then we continue with inhalation techniques, of course. We teach our patient how to do properly inhalation, because most of them, they do mistakes during the inhalation. So also we continue with the best technique. So it's autogenic drainage. And then we have here assistive, active cycle breathing techniques. We use it. We have assisted autogenic drainage, where we use for babies and for kids, mostly for babies, sorry. And we teach our patients how to expectorate the mucus. We don't let them to cough more often, because we prefer to use half techniques, because the coughing causes inflammation, and that's why we have that cycle that I showed before. So we have, again, accumulation of the mucus. And also, there are some devices that we use during the treatment of CF patients, where here also our colleague showed that we have postural impairments, and that's why sometimes we assist it by sports activities, and of course, most important thing also that I use most frequently in the CF patients is the fascial release. There are a lot of fascial techniques that we ease to patients during the coughing, when they breathe. So you will have, of course, we have a lot of improvements during their life, of course. And the most also important part of our work is pelvic floor exercises. We know that most of cystic fibrosis patients, they have urinary incontinence, and we use different techniques to, sometimes because of the tension of the pelvic floor muscles, we release that pelvic floor muscles, but sometimes we have weakness where we use strengthening exercises to activate these pelvic floor muscles. So, who knows and who doesn't know, so autogenic drainage is a respiratory self-drainage breathing technique that uses controlled breathing of different lung volumes to move secretions from target airways. It is characterized by breathing control, whereby the individual adjusts the rate, depth, and lung volume of their breaths. It can be individually adapted to diagnosis and lung function. Also, it uses the principles of unstick. We unstick the mucus, we collect, and we evacuate to move them through lung volume airways. You know, I came from North Macedonia. Long time ago, they used also, the nurses used tapping method. Of course, that's why we went to educate ourselves, where we learn properly how we need to drainage this mucus to expectorate or to evacuate this mucus in the correct way. Also, there are still more countries that they use the wrong technique to evacuate the mucus. First time was developed in Belgium in the late 1960s by Jean Chevalier. During 1980s, it was utilized throughout Europe to treat asthmatic patients who had suffered retention of secretion in the chest and difficulty in clearing the secretion. So thanks to Chevalier, we know this technique, we learn it, and we use to help CF patients. So this is how that works. We have a graphic show how autogenic drainage it works. The most important part when we work with autogenic drainage, so it is to focus on the patient, how he breathes, where we use our ears to locate the secretion, to feel it, and of course to communicate with the patient where does he feel it, the obstruction. That's a very important part where we can work in that way. So we do. First we do normal breathing, like active cycle breathing techniques, and then we start with full breathing, breathe out full, and it is the way how we collect the mucus in the second phase, and then in the third phase we evacuate that mucus by using huffing, of course, not coughing. And all the time we teach our patients to open the glottis during the work. So we use these devices where we practice the autogenic drainage. During our practice, we use devices, of course, to help us more, to ease our way to evacuate the mucus. This is where with kids or with babies mostly we use bubble pep, so it's very funny for them. It's positive expiratory pressure by using a bottle with water and with, of course, by using soap. The flutter also is helping us, of course, mostly the best device that we work mostly, we use mostly with that vibration where we collect this mucus. And we have here a cappella. It's very useful because we can use it also in different positions. That's the benefit of this device. So this is me where I work with a CF patient here. And we used, of course, we have two types of a cappella device. So we have the blue one with less frequency of oscillations or vibrations. And we have the green one for adults where we use because the vibrations or frequencies are higher than the blue one. And here is the one case where I worked with by using all these techniques just before the treatment. So the forced expiratory volume was 46%, whereby the forced vital capacity was 72%. You can see also here. This is before the treatment. And it is really interesting that after 10 days, we have this. So the forced expiratory volume we go back from 46%, so we have 69% improvement. Only with autogenic drainage, and of course, I give advices by using mostly cardiorespiratory activities. And also you can see that and the forced vital capacity was increased to 90%. The next case is that we get some improvements here. This is before the treatment. So we had the peak expiratory flow was 1.68 liters per second, while the FEV1 was 15%. And the forced vital capacity was 20%. So you can see these parameters here. After the treatment, the peak expiratory flow was increased to 39%. The forced expiratory volume was increased to 26%, and the forced ventilatory and the forced vital capacity was increased to 38%. So these cases are treated by autogenic drainage and for short period, not for long period, whereby I wanted to be sure, but by using this measurement tool to see how fast it acts. So how fast we can get the improvement during the use of autogenic drainage. So we have really fast improvements whereby, and the feedback of the patient also is very important, where so we have a lot of improvements where also the patient told us after the treatment, after using the autogenic drainage, and that's after all of this treatment. So the conclusion is that the spirometry results show an improvement in lung function, especially in FVC and FEV1. So although the obstruction with possible restriction is still present, because this is a short period of treatment, the improved values suggest better ventilation. Okay, so the autogenic drainage is the best physiotherapy option of treatment to prevent further lung obstruction by clearing the excessive mucus in the respiratory tract. Autogenic drainage also increases the ventilatory capacities by increasing the spirometry parameters that we saw before. Thank you for your attention.
Okay, thank you. So all the presentations were presented, but this is not the end of session. Actually, now we open the very last part of this block of this session, and that's discussion. So please, now you can ask, all the speakers. So maybe I will kick off, and of course I will start with the microbiology part. Okay. So Dr. Begoli, I would ask about the universe. So you showed us. Yes, you showed us that you use multiplex PCR for the pneumonia panel for cystic fibrosis patients. Mm-hmm. We know that this panel is not designed for cystic fibrosis. Some of the pathogens are missing. You don't have Burkholderia, you don't have Achromobacter, you don't have fungi in that. So my question would be, and it's very expensive also. Uh-huh. What would be your indication? So in which instances you actually run the panel, and what would be the added value of it because of the, of the money, of the budget? So mm-hmm. If you can maybe comment on this a little bit more.
I already said that the efficiency of this is because these panels for testing are very expensive, and we cannot make it or test it routine patients, all the patients who have diagnosed with CF, but we have initiated, we have had 40 panels. First 40 panels we tested in the lab, and we have required from the administration that they should supply again with a bit higher number of panels, and we do consider to use it on the patients that the clinicist assesses the therapy is not going well in a more aggravated situation, or it is the therapy is persisting, they are not intaking antibiotics, and I would consider to make this, to use this diagnosis, because the clinicist obtains the result within 5 hours, and this gives time to the clinicist to act quicker to start treatment with antibiotics. In fact, we are quite young. This is the first time we are using this panel, and we are learning, but I do consider, in order to use it on patients which is required by the clinicist, feels the clinical situation, how the patient is going, then the background, if there are isolates, multi-resistant on these patients. This is for the beginning. So I already said in the previous slides, I do consider to make this as a routine to test on all patients with a priority with diagnosed children with this disease.
Are there other questions to any of the speakers? So maybe I will ask, I will ask Dr. Destrop about the HIT-CF project. Can you just please, maybe I just, overlooked that. So what are the patients included in the clinical trial? So are, in terms of the genotype, so are they all with the class 1 mutations only?
No class 1. No class 1 mutation. Oh. No class 1 mutation. So deletions are excluded from the trial. Yes.
Okay, so which mutations? So are there from the residual function mutations,
Yes.
for instance?
Yes. Every mutation except for the deletions and F508L. Yes. But we are still blinded for the patients that are currently entered into the trial. Good.
Okay.
May I ask you a question? I want to ask a question to Pavel. You showed us novelty about innovative molecules in CF, and you show us that vanzacaftor has a better effect on reducing sweat chloride, but it shows no difference on clinical parameters on patients. So my question is, if I have a patient who is going well on ETI, has no adverse reaction to the drug, and as is stable, would you recommend switching to vanzacaftor or not?
Fabio, I would love to ask this question to someone else as well. And I'm waiting for maybe the guidelines for some of the very progressive countries and nations where Aliftrek would be available sooner than in my country. So to be inspired, under which conditions you would switch from Kaftrio to Aliftrek. So my understanding is, the trial was designed to show non-inferiority of the new molecule compared to the standards of care. So vanzacaftor with these other two molecules compared to alexacaftor with the two molecules. It showed very comparable results in terms of the lung function. Sweat test results might indicate that there is the higher efficacy on a molecular level. Definitely, because there is something ongoing with this biomarker, with the sweat test. So we can, of course, speculate that it is more efficacious, maybe on long-term basis. But it is, of course, too early to draw any conclusions. So I can't answer who would be definitely eligible for the therapy, except for those who don't tolerate, current treatment. You see the side effects of the Kaftrio therapy, don't tolerate it. So that's pretty obvious. But in general, if it would be like more people to be switched to it, I don't know.
Thank you. Are there any other questions from the audience?
Looks like everything is clear. So thanks everyone for joining us until these late hours. We'll have a quick picture with some trophies for the lectures. Could you please join the lectures? Join us here on the podium, and then we can have a cup of coffee outside until the hall gets ready for the workshops. Okay, thanks everyone.